Good evening, everyone. It's 7, so let's start the second part of the 7th masterclass. For those of you who are joining today for the first time and did not join yesterday, Jaipur Surgical Tutorial is an online education portal which we have been running for the last more than 2.5 years. This is managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery at my new institution, the Mahatma Gandhi Medical College Hospital in Jaipur in Rajasthan. And we conduct a session every Saturday, 9 to 10 a.m. Indian time. I will, in between the sessions, post the information how to join Jaipur Surgical Tutorial. In addition, we've also started a special class on Friday afternoon, 3 to 4 p.m. on the request of colleagues from Africa because they could not join on Saturday morning. So that also I will put the information as to how to join that. And we, a few months ago, decided that we will try to cover a single theme, a single topic in a masterclass, which usually runs for 2 days. Usually it's Thursday, Friday, but this time because Friday is a national holiday for us in India, we are doing it on Wednesday, Thursday, 7 to 9 p.m. We've already conducted 6 master classes. All those videos are available on the net, on the YouTube channel. Again, the link will be provided once you join any of these groups. And the theme for this 7th masterclass is bile duct injury. Only the acute bile duct injury, not the established biliary stricture. So we are dealing only with bile duct injury. We covered some topics yesterday, and there are a few more topics to be covered today. The moderators for today's session are two very important people. Dr. Mohammad Ibrarullah, who is the second batch MCH alumnus from SGPGI Lucknow. He is now a senior consultant at Apollo Hospitals in Bhubaneswar. But I think his credentials for being on this masterclass as a moderator is that he, along with Dr. Sikora, has published an excellent, very well and very heavily illustrated atlas of safe cholecystectomy. It's a very expensive book, but I would urge all surgical colleagues that if possible, ask your department, ask your institution to get a copy. It covers all aspects of how to keep a cholecystectomy safe. And the second moderator for today is my former colleague from SGPGI Lucknow, Dr. Behari, one of the most scientific, compassionate and safe surgeons that I have worked with. And she's also very passionate about keeping the cholecystectomy safe and the problem of bile duct injury. So with that introduction, I'll hand over to Ibrar and Anu.
Hi, good evening, everybody. So I suppose we can start right away with the first topic, that is when to suspect a bile leak after cholecystectomy, particularly when there is no drain. So it's basically all a clinical suspicion, and everything has to be based on your clinical suspicion and your intuitiveness and all that. So this will be by Dr. Kailash Kurdia. Suppose he's from Jaipur only, from your center, Dr. Kapoor center. No,
Kailash is
from PGI
a former student from SGPGI. He then went on to PGI Chandigarh.
Yeah, he's presently in PGI Chandigarh, right.
He's currently the assistant professor at AIIMS New Delhi with the AIIMS group. Actually, Kailash had a personal tragedy at home, so he's currently traveling, but he has sent his presentation to me, which he had prepared. So I will replace him. I'll try to do justice to the topic using his presentation, which he had prepared and sent to me. So I'll do it on his behalf.
Right, sir.
Okay. So are my slides there?
Yeah, you can see.
Okay. So before I start, I would also like to welcome Dr. Sikora, who moderated yesterday's session, and Dr. Sadaf, who's the chief of GI surgery at SKIMS, and Dr. Abhinav Sharma, who is a senior gastroenterologist, medical gastroenterologist in Jaipur. He's also an SGPGI alumnus, and he's one of the panelists today. He was there yesterday to make some comments about endoscopic management also. So this is the presentation prepared by Kailash. When to suspect a bile leak after cholecystectomy, and as is usually the case, we don't leave a drain unless we anticipate a problem. Most of us do not routinely place a drain. So we have a patient who has undergone a lap chole. There is no drain. Now the issue is when to suspect a bile duct injury. And all my colleagues who are either attending or will watch this video, we have to remember that it's a peculiar problem with lap chole that majority of the injuries are not detected or even suspected during the cholecystectomy. They are suspected or diagnosed after the cholecystectomy, in the post-operative period or in the follow-up. And this is in each and every report, this holds true, except the group which uses routine intraoperative cholangiography, which is not the practice in most centers. So we have to keep it in mind that the fact that you thought that the cholecystectomy went on well does not mean that there is no problem. You have to keep a very high index of suspicion in the early post-operative period, after discharge, and in the follow-up also. So the issue here, which Kailash wanted to highlight, was that since it has become a routine, since almost everybody is now doing laparoscopic cholecystectomy with better and better anesthesia and perioperative care, the recovery is getting even better and faster. And therefore, many groups are now practicing lap chole as a daycare surgery. Patient comes in the morning, goes home in the evening, doesn't even stay overnight. Although I personally prefer, and it has been our practice, that we keep the patient at least for one night in the hospital. The only exception, Anu would remember, we have made is a young lady who has a small child who's breastfeeding. And if these are the cases which we post very early in the morning, first case, and if there is good, complete, full, satisfactory recovery, we may allow her to go home in the evening so that she can look after her young child and insist that she comes back to the hospital the next morning to have a routine checkup as if she was in the hospital. So that is the only exception. But I know that many centers are now practicing lap chole as a daycare surgery. Now, this is one report which Kailash has cited, that they found that as many as 80% of cases were suitable, and out of this, 96% could be discharged the same evening. But 3% did require readmission within 48 hours or after 48 hours. And a small number of cases required re-intervention also, although there is no comparison here. But what he has tried to say, that even in our own country, and this is a report from the base hospital in Delhi, that lap chole is being done as a daycare surgery. This is another report from PGI Chandigarh, where the percentages are less. And they said that if you practice it as a daycare surgery, you have to be extra cautious. You have to give clear instructions to the patient. The patient has to understand them. The patient should be ready to come back if and when there is a problem. And you should have a system that if the patient comes back, the patient is attended to quickly. Again, I would cite an instance where we did a lap chole at SCPGI in a young man who had no comorbidities. He went home. This was not daycare. This was routine one night stay. He came back with some vague, non-specific symptoms to the emergency. The emergency team saw him and they did not suspect, or they did not understand the gravity of the situation, gave him some symptomatic treatment and sent him back home. Now the patient was reassured that doctors have seen me, everything is fine, nothing major problem is there. But the problem continued and he returned after 2 or 3 days. And by that time, the patient had developed severe systemic sepsis because there was some bile leak and went into irreversible multiple organ failure. In spite of a re-intervention done by us, we could not save this patient. And this patient, I don't think I would forget throughout my life and maybe after my life also, because this was completely avoidable outcome if the patient had been seen by a member of our team when on the first day he came to the emergency. So one has to be very, very careful when you practice a daycare lab chole. Now, what do we expect after a lab chole, especially? On the evening of the operation, if it was done as the first case, but if it is later, then at least by next morning, the patient should look well. I always tell my students that when you go and see a patient next morning in your morning round after a lab chole, the patient should say hello, namaste, or whatever to you. She should be sitting up in the bed and she should look like as if she is a pre-operative patient. That is what we expect after a lab chole. She may have some nausea and some pain depending on the sensitivity of the patient, but it should not be so severe that it requires injectable. Either she should be able to tolerate it, or maximum you may have to give some oral medication which should relieve it. She should have taken a cup of tea, maybe a few biscuits. She should have gone to the toilet and passed urine on her own, which means that she's out of bed. And she should be asking you, doctor, can I go home? That is what is expected after an uncomplicated lab chole in a otherwise healthy, fit patient who has no severe comorbidity. But does this happen? And why it does not happen? It does not happen because of bile leak. Now, yesterday also we discussed that in some classifications, a bile leak from the cystic duct, from the cholecystohepatic duct, or from a small aberrant duct may be classified as a minor injury. Actually, in my opinion, there is no entity like a minor injury. Injuries are injuries. The duct may be minor, but the injury is not minor because the consequence is same. Consequence is not because of injury per se, consequence is because of the bile leak. And the incidence of bile leak, if you look at reports from all over the world, ranges from 0.5 to, if you look at data from countries where there is a prospective mandatory audit, it is even more than 1%. And this percentage has not changed overall over a period of time. So now lab chole has become part of surgical training, but still bile leak continues to be there. So it is an inherent problem of the procedure per se. Now, this is a very old report, 1989, and it shows that when routinely an isotope scan was done, a significant number of patients had bile leak. It may not have resulted in a consequence, but it is there, it is common. So there is no reason why that would have changed. And this is the report which says, this is again an old report, that the incidence at this time was the same, 1%, and the commonest manifestations were pain, fever, and tenderness. But note the point, the duration of interval between cholecystectomy and presentation, 5 days, which means the patient is at home. Patient is not in the hospital, because we don't keep these patients for 5 days. So what I'm trying to say that even if the patient has gone home on day 1 without any problems, it doesn't guarantee, it doesn't mean that there is no problem. There could still be a problem. Patient may develop symptoms later. And this is a very large report, a collective kind of experience, which again shows that bile leak and bile duct injury rates are to the tune of 0.4 to 0.5%, which means 1 in 200. 1 in 200 lap colis will have problem, and these are the various sites from where bile leak can occur. Now, bile in the peritoneal cavity behaves in a very erratic fashion. We all have seen patients with litters of bile in the peritoneal cavity, biliary ascites, and roaming around in the OPD with no sepsis. On the other hand, even small amount of bile in the peritoneal cavity can cause havoc. This patient, which I referred to, when we re-explored him after about 4 or 5 days, we didn't find more than 50 or 100 ml of bile in the subhepatic area, but he had gone into severe systemic sepsis. So that is why if you proactively look for bile leaks, you will find them in more patients than you clinically suspect or detect, because many of the small leaks may not cause any problem. And because the duct injured is small, it closes on its own without any consequence. And you don't even know that there was a bile leak. But if there is a significant amount of bile which is leaking out, it can manifest as either a biloma, which is a localized collection of bile, usually in the subhepatic area. But look at the subphrenic area also, look at the left subhepatic area, the lesser sac also, and look at the pelvis also when you are doing an ultrasound. Bile ascites, which is bile in the entire peritoneal cavity, free bile, or with or without sepsis. So bile ascites or bile peritonitis. And then, of course, if you have a drain or if you place a percutaneous drain, it becomes a fistula, which is controlled. But if it comes out through the port side, it becomes an uncontrolled biliary fistula. Biloma is the commonest manifestation, but the most serious is biliary peritonitis. Biloma would cause sepsis, but it may not cause systemic sepsis, whereas bile peritonitis will usually cause systemic sepsis and multiple organ failure. So the range is from asymptomatic bile ascites or biloma to fatal lethal biliary peritonitis, and it depends on amount, on the presence or absence of bactobilia, and as I said, an individual variation depending on the immune response or the body response of the patient. Any untoward, unexpected symptom in the post-operative period is an indicator or at least a suspicion of bile leak unless proved otherwise, which means that if the recovery is not as expected as I described earlier, one should think that there is something wrong. And something wrong after lap chole is bile leak unless proved otherwise. There could be other complications also. There could be bleed, there could be a duodenal injury, there could be colonic injury, but we must first think of bile leak. And if we investigate for bile leak, the other injuries also we will find. So if the patient has unusual pain, which is out of proportion to what your other patients have had and which is requiring injectables even on the next morning, or if the patient is having so much of anorexia and nausea that she doesn't even want to drink a cup of tea, she's not comfortable, she's tossing around in the bed, you need to think that there is something wrong. So again, the statement that if the patient doesn't feel well, doesn't wish to get out of the bed, does not eat or does not wish to go home, you need to suspect a bile duct injury or bile leak. If there is any abdominal finding on examination, because on the following day, the abdomen should be completely soft, non-distended, non-tender with normal bowel activity. If the abdomen is distended, if it is tense, if it is tender, if the sounds are less than what normally they should be, there is something wrong. If the patient has any tachycardia, tachypnea, fever, hypoxemia, And if you do a complete blood count, any leukocytosis, then again, there is something wrong. And I would repeat, something wrong means bile leak unless proved otherwise. So any variation, any deviation from the expected post-operative course should make you suspect that there is something wrong. And the problem is compounded because we, unfortunately, and that should not happen, tend to take lap chole lightly. Because we have so many other patients, we give less attention, unintentionally, of course, to a patient who has had lap chole, thinking that everything would be and should be and is all right. And the patient is not observed properly as it should be before or after the discharge, as compared to another patient who has undergone a major operation. So my request is that lap chole has to be taken as seriously, and I would say even more seriously than a patient who has undergone a major operation, because after a major operation, everybody is attending, everybody is attentive, everybody is careful. These are the patients in whom, if you have a slightly, I wouldn't say careless, but not very careful approach, you will miss a bile duct injury, which otherwise should have been detected. So again, Kailash has quoted a report of these patients who had undrained bile collections, and undrained bile collections resulted in serious complications, including sepsis and organ failure. If there is bile in the peritoneal cavity, it has to come out. And therefore, it is very important to find out if there is bile in the peritoneal cavity, because if it is there, it has to be taken out either by percutaneous radiological intervention or by surgical intervention, which could be a re-laparoscopy or laparotomy. But most cases these days do not require surgical intervention, because if you have good radiological support, interventional radiology, it can be done by percutaneous intervention. And there are reports which say that patients who ultimately were found to have these bile collections, initially it was either not suspected or it was discounted. That patient had some problems, but we said, no, 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 you are all right, go home, nothing to be worried. So this is frequently reported in a series of bilomas or bile collections. Again, a report where it is mentioned that as many as 87% of patients, the injury was not recognized during cholecystectomy, and these patients were discharged home without a detection. But retrospectively, it was found that many of these patients had bothersome symptoms, which should have been attended to, which should have been looked into. And a large number of patients in whom a bile collection was detected later, it was found that there were some symptoms which were non-specific, which were insignificant, but they were there. And therefore, any symptom present on day one after lap chole should be followed up, should be investigated while the patient is in the hospital. So again, the same thing, the details of these reports. And the commonest problem is bile leak. Of course, there could be other problems also. There are various reports which say that once the patient has been discharged, because then the patient is not under your observation, these collections are missed, they are detected late, and there are reports saying that even up to 9 or 15 days, these collections remain undetected, because the collection obviously happened during the cholecystectomy. The only exception of a delayed collection is when it is a cautery injury, thermal injury to the bile duct, which doesn't cause bile leak during surgery or in the early post-operative period. It is after 3 days, 5 days, 7 days that the wall sloughs, necroses, and then there is a delayed bile leak. And therefore, it is very important to give instructions to these patients that they must come back at least for one follow-up. And even if they are not coming back for follow-up, if there is any problem, they must come back to you, or at least they should see a surgeon. So Kailash has put some concluding points that symptoms of bile leak or bile collection are very, very subtle. They are usually overlooked, and this is responsible for the delay in diagnosis. And delay in diagnosis is responsible for onset of systemic sepsis, multiple organ failure, and mortality. So we should keep a close watch. We should have a very high index of suspicion of a bile leak after a lap chole. And if the patient is not recovering as smoothly as expected, again and again, I'm repeating this point, this is the most important sign that there is something wrong. Pain and tenderness, the classical signs are found in very small number of patients who ultimately had bile leak. There are non-specific symptoms. And if these collections are diagnosed in time and drained, then we can avoid serious complications of systemic sepsis and multiple organ failure. So this picture he borrowed from me. This is one of my patients who, before we started the ward rounds, we usually stand on the counter and discuss some things, the ward counter. And she came and said, she addressed me as uncle. She said, I want to go home. Can I take a selfie with you? So that is the expected recovery. If it is not there, you should suspect there is something wrong. And again, I would repeat, something wrong after lap chole means bile duct injury, bile leak, unless proved otherwise. Thank you. So as I said, this was the presentation which was prepared by Kailash. Unfortunately, because of a tragedy in the family, he could not be joining. He is still traveling. And then I told him that I'll cover for him. Thank you. Over to Ibrar and Anu.
Yeah. I'll make just a few comments. I think this has been adequately emphasized by Dr. Kapoor, that the first appearance, when you next day, when you go to the rounds, that is where you get the first impression. I mean, what I do is I just look at the face of the, are you ready to go home? And most often they would say yes. Getting up from the bed, that is where you suspect. And the first thing is put your hand on the pulse, his or her pulse. Tachycardia is a very important sign, and that really alarms me. Like, there is probably something wrong before I go on to examining the abdomen and looking the other things and all that. So tachycardia is a very important symptom because fever and all those things would come little later. But first thing that is to appear is a tachycardia that you must not ignore. Any patient post lap chole first day having tachycardia, then that has to be taken seriously, and then the rest of the thing has to follow after that. And as regards the course of the behavior of this patient, as I said, it is, as Dr. Kapoor has said, this is very, very unpredictable. In fact, if I have to recall a patient of mine, it was a little difficult cholecystectomy, but 24 hours next day, he was rather, little vague, complaint, this and that. Evening, I found there is little bile in the drain. This is, I would say, 24 hours after the surgery, I noticed little bile in the drain. Yet the patient was comfortable, mild tachycardia. So I said, in any case, he has a drain, so let me defer the management till next day. By 36 hours, he was febrile, showing all signs of sepsis. Then obviously I took him for, what is that? ERCP and a re-exploration. Not exactly, it's a re-laparoscopy where we did there was a lot of bile collection in the abdomen despite the drain. That was all drained, did a ERCP stenting. But then after that, he never recovered. In the next 12 hours, he had gone into ventilator. And by next day, he was, we lost him. So that is how it behaves. Like within 48 hours, the patient was no more, despite the fact that we intervened after 36 hours. It was not that late, or we did not really ignore his signs and all that. But all the same, you have to do whatever you can do, your best in these situations. So that is that. Anu, I think.
Yeah.
Anu, any comments?
Yes, sir. I mean, I think there is really, really, we need to stress this. Lab chole suffers from, what we call familiarity breeds contempt kind of thing. We take it really lightly sometimes. And as Dr. Ibrar has also shared, sometimes even when like you've seen a little bile leak, but you think, okay, there is a drain, we can never be complacent. And it is better to overdo in terms of investigation than under. So I think this point, and that is why I think it appeared as a repetition, but it is important for that repetition that no undue symptom, like anything, a minor deviation from the expected post-op course should definitely put us on high alert, and we should do everything. And I think Dr. Sadaf will cover that in the next, as to once you start suspecting, what should you do?
I think before we invite Dr. Sadaf, may I ask you this quick question? Like, what are the situations where you would like to put a drain after cholecystectomy? Rather than, most of us won't do it, but there are situations where we would want to put a drain. So, Dr. Kapoor, can you please just...
Yeah, if it is not a simple gallbladder, if I suspect or anticipate that there is going to be a problem, I would over react and place a drain. So all partial cholecystectomies must be drained, because there is now evidence also that if you're doing a subtotal cholecystectomy, the incidence of post-operative bile leak can be as high as 10 to 15%. So all subtotal cholecystectomies must have a drain. A difficult gallbladder, where you are not happy with the clipping or suture ligature or stapling, whatever you have done, it is better to put a drain. If during surgery, as we discussed yesterday, not in the Calot's triangle, because that indicates a main ductal problem. If in the gallbladder bed dissection you found that there was some bile, and you either controlled it with a clip or you took a suture there, then again it is better to leave a drain, because it is likely that you may have a continuing bile leak in the post-operative period. A very inflamed cystic duct, especially if you are operating on acute cholecystitis, the inflammatory edema, if you use a titanium clip, it can go through the edematous tissue and result in a bile leak. If you are using a hemolock, and once the edema subsides, because now the offending agent, the stones have been removed, the clip may become loose and there could be bile leak. So in that situation also, I would definitely prefer to leave a drain. So if there is any anticipation of a problem, it is better to leave a drain, because if you don't see any bile the next morning, you can remove it and the patient can go home as per plan.
Yeah, another quick point, before we move on to the next speaker, is about this subclinical bile leak. Dr. Kapoor, you quoted a study where earlier, there's a pre-lab coli study where the incidence is up to the tune of, I think, 20 to 30%. But we also did a study, and I don't exactly remember the percentage, but I don't think it was that high.
No.
Yeah, so probably I think the earlier study was flawed.
I think it was just an isolated study which Kailash, but I think the idea Kailash must have in mind is to highlight the fact that even in that era, even in open chole era, bile leaks were frequent. And yes, many of these bile leaks may not be clinically important or relevant or significant, but we need to be looking for them. And
could you remember what was the incidence we found in our study? I don't really.
No, it was way back when you were there.
Yeah, that was in World Journal of Surgery.
Years.
We published that, yes.
Yes.
But suddenly it was in single digits, suddenly not.
We still have 5 minutes. So if any of the other panelists, I think Sadiq has raised his hand. Sadiq? No, sorry. So any other panelists would like to make any comment on this topic, how to suspect, because this is the most important part of the whole scenario of bile duct injury before we move on to Sadaf. Yeah, Sadiq.
Good evening, everyone. Thank you. Now, I just want to, apart from all the important things which have been highlighted, one of the things I always say is, of course, in all patients, but specifically, especially in a group or when they're residents, they should be aware of how the cholecystectomy went. That means, was it a difficult cholecystectomy? Was there any issue during the cholecystectomy? How was the gallbladder? This information is preloaded in your mind when you're looking at the patient the next morning. And where there is an increased suspicion of problem, and that patient, if the patient is not doing well, you certainly double your suspicion for possibility of a bile leak and collection in those. So that is an additional this thing. And about drain, I just want to say that we've all the points or indications which you said, but now we are going away from putting drain in most, except when we are doing a subtotal cholecystectomy. But if you suspect that there was a problem or like edematous tissues and all, then of course you should not hesitate to put a drain. But I think since drains are getting off as a routine, the clinical assessment of the patient becomes very important before you plan for a discharge for these patients. And you both have highlighted cases where there is a sudden deterioration of these patients having missed a clinical scenario.
And sir, I was remembering what you had said about reviewing the recording if you have. So this comes to mind always whenever a patient is not having the usual course and all. And if like you were not there at the time of surgery, especially, so, apart from asking as to how it was, this visiting the recording is also very important for this also.
Anand is my colleague, as I mentioned earlier. He is the one who's been managing the Jaipur surgical tutorial for last almost 2.5 years.
Good evening, sir. Good evening, respected speakers also.
Right.
Sadaf, any comment on this topic before you go on to your topic?
Yes, I had to make a little comment because our audience is for safe cholecystectomy and for beginners. I would like to say that you do not put a drain, is we are talking in terms of people who are masters in the subject. But we would put a word of caution, other than most of us are not putting it. Like our subset of patients are all high risk cholecystectomy. We put it in most of the patients, and the beginners who have just qualified, and they are the bigger chunks of doers of lab chole in bigger numbers. I think genuinely they can put drain in initial phase of their career.